to thank Consummate for the invitation. I was so excited about coming in Cartagena, Colombia this year, and unfortunately it will not be able to meet in person this year due to the pandemic situation. And I thank Consummate for the huge work in organizing such an amazing meeting virtually, and I'm so honored to be part of it. We will talk about scleral lens complications. I've been asked who taught you to fit scleral lenses, and my answer was my errors. Because when fitting scleral lenses and managing the problems, indeed, I learned a lot. Every time an issue or a complication occurred, I wanted to learn, to study, and to learn from it. And that's why I decided this title of the presentation, Embrace the Complications and Learn from Them. I mentioned issues and complications because it's important to differentiate and classify scleral lens problems. Issues may not cause persistent alteration to the ocular surface, while issues are reversible. They may affect patient satisfaction and lead them to discontinue scleral lens wear. And complications are adverse events that cause persistent alteration to the ocular surface. Here I made a further classification based on etiology. Issues and complications may be related to non-optimal fitting, relationship with the underlying sclera, and to handling, care, and compliance. There are various issues and complications, and here we will see a few of them. Corneal touch is different than corneal bearing. Corneal touch is when the lens touches slightly the cornea, and the corneal bearing is when the lens rests partly on the cornea, which supports a part of lens pressure. Corneal touch or bearing do not frequently occur when fitting scleral lenses, since the scleral lens vault over the cornea and the limbus. Assessment with the slit lamp will localize thinner areas of clearance when observing an optic section or dark areas using diffuse illumination with cobalt blue light. The evaluation with the OCT will show areas where clearance is absent. When corneal touch is located centrally, it's caused by flat fit necessitating to be steepened. In this case, oval air bubbles will appear in the peripheral cornea, indicating a flat fit. When we have a peripheral touch, it may be caused by peripheral ectasia. In this figure above shows central and peripheral corneal bearing. In this case, a scleral lens is fitted on a patient an eye with the keratoconus, and the figures below are of the same eye. The first one shows a profile view of a very rare condition, pellucid marginal degeneration decentered superiorly. The OCT image shows a 20.60 mm scleral lens bearing on the decenter apex. In these cases, it's necessary to increase peripheral clearance or include a localized vault peripherally, like in this case of Dr. Reef, where a scleral lens with localized area of increased elevation in the peripheral corneal zone was designed for patients with Salzmann nodular degeneration. Here there is a view of the lens with the localized vault in the peripheral corneal area. The optic section observation showing the clearance in the increased vault area, and the OCT image of the scleral lens applied on the eye showing the localized vaulting over the elevated corneal area. Peripheral touch can be caused by a prolate lens fitted on an oblate cornea. So switching to an oblate scleral lens design will resolve this issue. Also, a scleral lens of small diameter may touch the peripheral cornea, increasing scleral lens diameter. The corneal and limbal zones diameter should be larger. Air bubbles, while with fenestrated lens, an air bubble is an essential and necessary feature. Air bubbles in the fluid reservoir is the most common issue related to sealed scleral lenses. When they are small and floating, they may be acceptable because they may disappear after lens assessment and do not interfere with vision. Large bubbles, like in these figures, should be managed because they may cause corneal delain formation and the corneal desiccation in the area where they appear. Air bubbles may be the result of handling issues. It's important to overfill the lens until the solution appears convex over the lens. It may be caused by an improper lens application technique. Educating the patient on proper lens application techniques is essential. Here is the patient education workstation for lens application and removal. There are two mirrors. The flat mirror is helpful for the patient for fixation and to keep leaning the chin to the chest. And both flat and vertical mirrors allow the practitioners to monitor the patient when applying and removing the lens, and so to correct if there are errors in lens handling. The eyelids should be open wide and held tightly from eyelashes attachment because they may cause lens decentration, creating air bubble formation upon application. The dominant hand will serve for lens application. There are two methods for manual application with 2 or 3 fingers. In case of difficulties, the use of device for lens application is helpful. There are two kinds of plunger for lens application, a smaller one and a larger one. Generally, the smaller one is indicated for RGP corneal lens application, but sometimes patients may be intimidated by the use of larger plungers, so the use of the smaller one is indicated in these cases. And there is no problem with suction forces. Like here in the video, you can see a small plunger is holding a large lens of 18.70 millimeters lens. Vented scleral lens plunger may be helpful to improve target for lens application. When vented scleral lens inserter is not available, you may snip the application plunger that you have. The use of edgy scleral lens applicator, orthodontic rings, or 8 O-ring provides stability for lens application. The application method using this ring is similar to that with soft lens application. The lens is applied with one finger, the index, and the middle finger of the same hand serve to open the lower lid, and the index of the other hand will serve to open the upper lid. This is very important to consider for those patients who were previously fitted with soft or corneal lenses who are used to this method. Seeing green lens inserter device is very helpful. It has a green LED light for a better fixation and lens centration. It's possible to use it without the plunger stand like the other plungers, or with the plunger stand, allowing patients with difficulties to use both hands for lens applications. Chiara Chio Smart Contact Lens Inserter and Remover has a detachable plunger that can be placed in the application and removal position as needed. The device should be held with the dominant hand, placing the end of the device on the tip of the finger, the index finger. The first image is showing the application position and the other figure indicating the removal position.
Whether you're helping your patients with the daily irritation of dry eyes or combating other ocular surface diseases, Boston Sight Scleral has the data-backed science and experience to help them see the world through a whole new lens.
The S5 scleral and hyperlens insertion system give the user 2 free hands to hold their eyelids open when applying the lenses. It includes 2 configurations, the S5 Mini and the S5 Inserter. The S5 Mini has a height from the base of the device to the top of the lens holder of 5.5 inches, which is about 14 centimeters, and it's ideal for lens insertion while sitting down. The S5 inserter has a height from the base of the device to the top of the lens holder, which can be adjusted from 10.5 inches, which is about 27 centimeters, to 2 feet 6 inches, which is about 76 centimeters. It's ideal for lens insertion when standing. LED light source is also included to enable the user to more easily align the eye with the center of the lens during application. A new device that Dr. Omar Flores kindly shared with me. In the center there is a stand for the lens and laterally the eyelids opener and holders. Actually, this device does not only provide a stand for the lens for better stabilization, but it also opens the eyelids like forceps, and the hand is only used to push the holder for lens application. When these applicators are not available, homemade devices may be used. Upside down coffee cup, a color pen, or cups may be used as stand for scleral lens applications. Here there is a bent plastic drinking straw to stabilize and extend the plunger for swollen or disfigured hands. This method was presented in poster at ICSC meeting in Fort Lauderdale by Dr. Vicente. So it's important to just cut above the bendable area and insert the plunger tip at the bended end. It may need to heat the end of the straw to fluid it and insert the suction cup, and to cut a small slit of the straw for the plunger to have a snug fit. To use a vented plunger, since it does not need to be squeezed to release suction of the lens. If the straw is strict, you can use a smaller plunger. A bottle cap used to create indentation on the finger when plungers or other tools are not available. This method may be used. The indentation on the finger will stabilize the lens during lens application. Also, this method was presented by Dr. Vicente. So if the lens descends on the plunger or fingers, it's necessary to reposition the lens to keep it overfilled with solution, avoiding air bubble formation. Patients should verify the presence of air bubbles. When air bubbles appear, the lens should be removed and reapplied again. It's important that patients cover an eye and verify if their vision is affected. Looking at the mirror and using the cell torch will help to identify the presence of air bubbles, and the use of a magnifier with the light make this identification easier. Air bubbles may appear due to poor fitting relationship with the underlying sclera. As stated before, oval bubbles in the peripheral cornea indicate a flat fit. Increasing central clearance by steepening the transition zone or the back optic zone radius will resolve this issue. Air bubbles may also appear to excessive vault with small landing zone. In this case, it's necessary to decrease lens sagittal height or increase the landing zone width. Air bubbles may also appear in the peripheral zone, and it may be due to a flat periphery or lifted lens edge. Steepening the lens periphery or lens edge is necessary. It may also be due to significant toric or asymmetric sclera. In this case, reducing the scleral lens diameter to avoid the interaction with the toric or asymmetric sclera is indicated, or switching to a scleral lens with a back surface toricity or a customized design may be helpful. If the lens is already toric or asymmetric, increase or decrease respectively lens toricity or asymmetry. If the lens is lifted off in the steepest area, increase lens toricity or asymmetry. And if the lens is lifted off on the flatter area, you need to decrease lens toricity or asymmetry. It's also possible to flatten the inner curves to move the bearing area close to the limbus, where the sclera is more likely spherical. Also, irregular conjunctiva may cause air bubble formation, reducing scleral lens diameter if the irregularity is beyond the limbus, or increase scleral lens diameter if the irregularity is near the limbus. Or introducing a notch may be helpful, and also switching to customized scleral lens may be beneficial. Avoid filling scleral lenses with aerosol saline, and use a proper non-preserved saline. Switch a non-fenestrated lens if the air bubble persists over the pupil, and the further recommendations may be the use of a more viscous solution for lens filling. Midday fogging refers to the presence of debris into the fluid reservoir, and it's a very annoying issue. This phenomenon appears only with scleral lens wear, and it's often transient, lasting few months of wear as the eye adapts. There are three types of debris: mucus debris appearing as small and white particles, diluted milk fogging associated with an atopic disease, and oil droplet debris. Atopic or ocular surface diseases will cause a milky fluid reservoir, so it's important to manage atopy and ocular surface diseases primarily to lens fitting. The presence of giant papillary conjunctivitis will more likely cause mucus debris. Reducing wearing time is indicated, and suggesting the use of hydrogen peroxide solution for disinfection and storage, or adding an enzymatic clearance to the care regimen to avoid the deposit on the anterior lens surface. Introducing a clearance with the sodium hypochlorite potassium bromide based system is also important. Reduce limbal vault when there is an excessive limbal clearance, which will cause mucus and oily debris. The OCT pictures show debris formation with high limbal clearance, and reducing the limbal vault allowed to clear the fluid reservoir from debris. Reduce vault diameter, corneal and limbal diameter if you notice a large vaulting diameter, and this will cause mucus and oily debris.
Miru 1 month delivers one of the highest levels of oxygen transmission, available in sphere, toric and multifocal. Miru 1 month contact lenses from Menicon.
Custom stable lenses change lives. They're intuitive, they're powerful, and anyone can fit them. It's time to simplify.
Check the lens edge. A scleral lens with a thick edge will alter lacrimal secretion and will cause debris formation. Oval limbus and significant toric or asymmetric sclera may be responsible for debris formation. Oval optic zone is indicated, and managing toric sclera is also needed. Debris may also be due to the release of cells from the cornea using solutions that are not compatible with the ocular surface, or in the presence of preservative sensitivity, and this will cause mucus debris. The use of preservative-free solutions for lens filling, cleaning, and storing is indicated. Switching to a fenestrated scleral lens may be an option. The holes included in the lens allow a constant tear renewal that flushes out debris from behind the lens. Washing eyes with an eye bath in the morning before lens application is helpful. Scleral lens may be applied, removed, and reapplied to clear the eye of the morning gun. and use a more viscous solution for lens filling. You can use also a balanced electrolyte solution for lens filling and introduce topical mast cell stabilizers. Avoid making breaks during the day to remove, clean, and refill the lens with fresh solution and reapply it again. This will worsen the debris formation. Instead, hold the preservative-free saline to the lens edge and squirt the solution into the post-fluid reservoir. And here in the video, fluorescein was used to show how this technique allows a complete renewal of the fluid reservoir behind the lens. Conjunctival prolapse refers to the loss of the conjunctival tissue that transfers beneath the lens. It occurs in elderly patients, in those with inflammatory conditions, atopy, limbal stem deficiency, pellucid marginal degeneration, in those who undergo several ocular surgeries, and in those suffering from dermatocalasis. It may be considered benign if after lens removal conjunctival tissue retrocede, and it should be managed when it adheres to the peripheral cornea and it induces neovascularization. In the first figure, conjunctival prolapse is evident in the inferior quadrant from 3 to 9 o'clock, and in the next figure, conjunctival prolapse is in the inferior and superior areas. Here we have conjunctival prolapse seen in OCT images. The first image showing the prolapse in the nasal quadrant, and the image below, the prolapse is in the inferior and superior area, more pronounced in the inferior area. Prolapse may be caused by several factors, including excessive central clearance, excessive limbal clearance, large vaulting diameter, and oval limbus. It also may be caused by compression caused by scleral lens on the conjunctiva, and when the blanching in the outer area, the landing zone is too steep. Flattening the peripheral corneal, limbal, and landing zone is necessary. When blanching in the inner area, the corneal limbal areas are too steep, or the landing zone is too flat. An excessive pressure exercised when applying the scleral lens on the eye may induce prolapse, so patient reeducation in these cases is essential. These two figures are of the same eye. Conjunctival process has recessed after decreasing limbal vault. Limbal congestion is an engorgement of blood vessels in the limbal area. It could be circumlimbal or sectorial. In the first figure, circumlimbal congestion is evident and is caused by scleral lens compressing the conjunctiva in the inner area of the landing zone near the limbus. The fluorescein pooling under the lens in the periphery in the second image confirms that the landing zone is too flat. So steepening the landing zone and flattening the corneal and or limbal areas are indicated. It may be caused by significant toric or asymmetric sclera or irregular conjunctiva, or because the landing zone is too steep. So it's necessary to flatten the peripheral corneal, limbal, or landing zones. It may also be caused by corneal and limbal areas that are too steep or landing zone too flat. So it's necessary to steepen the landing zone where blanching occurs, or by excessive pressure applied to the lens during application. So education, patient's education on proper lens application is needed. These figures show a circumlimbal congestion caused by lens compression, pushing the edematous conjunctival tissue in the corneal area. And the image above moderate congestion with moderate redness are showing the blanching in the inner area, and the lens edge lifting off indicate that the lens is fitted too flat. in the mid-peripheral scleral zone. Steepening the landing zone and flattening the corneal and limbal areas will resolve this issue. In the figure below, severe congestion with severe redness are showing. The blanching is in the outer area, showing a too steep lens. This figure shows severe congestion with severe limbal redness and conjunctival prolapse. The blanching is in the outer area, showing a too steep lens. Toxic reaction and hypersensitivity to solution may also lead to limbal congestion. The limbus is where stem cells are located, as are essential for corneal epithelium regeneration and proliferation. The limbal bearing may trigger epithelium failure, provoking several complications. Assessment with the slit lamp will localize thinner areas of clearance or black areas over the limbus, and the evaluation of the OCT will show the landing bearing over on the limbus. It's important to evaluate limbal clearance in the 5 direction of gaze. The eye is not static during the wearing time, therefore it's important to evaluate the fitting relationship with the underlying ocular surface in the different gaze directions. This OCT image shows the limbal touch in the horizontal meridian. Here is an evaluation of limbal clearance using the slit lamp with the diffuse illumination in cobalt blue light and the Wharton filter, staining the fluid reservoir before lens application. The first image is showing an inadequate limbal clearance, indicating an excessive limbal touch. The second one is of a moderate limbal touch horizontally and without limbal touch vertically, and the last one showing good limbal clearance without limbal touch. Limbal clearance may also be evaluated using the optic session in white light in different gaze directions. Inadequate limbal clearance in the images above, the slit lamp assessment of the limbal clearance showing a black area in the limbal zone, and the evaluation with the OCT showing the lens landing on the limbus. In the figure below, there is adequate limbal clearance. This is a case of harsh limbal bearing. There is an epithelium breakdown to the harsh limbal bearing, and the punctuate staining in the limbal zone is appearing caused by the limbal bearing. Limbal touch may be caused by scleral lens of small diameter, so increasing vault diameter is necessary. Lens decentration may cause a limbal touch in the superior area. Lens decentration is multifactorial, including a toric haptic, reducing limbal vault, optical oval optic zone, lens with larger diameter, or switching to customized lens may be a good option to manage lens decentration. And for limbal touch, increase limbal clearance when limbal vault is not sufficient. Tight fitting occurs when the lens is fitted too steep, like in this case of the image. The tightness of the lens may grow with prolonged wear. It's crucial to resolve this condition because it may cause various issues and complications. Lens of small diameter, lens with thick edge, and a steep lens may contribute to the issue of this issue. Also, scleral lens fitted too close to the ocular surface may cause tight fitting. A more loose fit may be indicated, and the fenestration in the scleral lens may help reducing suction. Introducing a hole in the haptic, as suggested by Dr. Carrasquillo, will help reducing the lens suction. In this case, to avoid conjunctival sticking, the lens should be fit with a looser fit. A swelled conjunctiva may cause tight fitting. In these cases, verifying the initial fitting assessment, the fit will appear ideal, but the swelled conjunctiva will alter lens fitting, appearing tight. So when inflammation and swelling resolve, blanching will disappear. A false tight fitting may also appear when applying the lens with excessive pressure. This case shows a tight-fitted lens causing by conjunctival circumferential blanching and conjunctival prolapse. The image below is of the eye immediately after lens removal, showing an impression ring left by the scleral lens, showing also a bulbar injection and the prolapse conjunctiva adhering to the temporal inferior cornea. Lipids and protein, as well as cosmetics and creams, can adhere to scleral lens surfaces during daily wear. The back surface of the scleral lens is likely to be accurately cleaned because it's difficult to rub due to its shape. In case of tear film quality and quantity issues, switch to deposit-resistant material. When removing the lens, rub and rinse the lens before lens storage to remove microbes, parasites, and debris. Removing debris will increase the effectiveness of the disinfection process and helps maintaining the lens surface treatments. Rinsing with a saline or multipurpose solution remove the cleaner and all residues from a lens surface. Use a hydrogen peroxide solution for disinfection and storage, or add enzymatic cleaner to the care regimen as indicated. Managing lid disease and atopic diseases if necessary, and verify the use of cream and cosmetics and provide suggestions such as apply the face cream, eye creams, and the makeup after lens application. Use a non-oily based makeup and avoid makeup to the eyelid margin. Verify the soap used. Prefer a non-moisturizing soap or those indicated for acne treatment. Use non-oil based moisturizers to eyelid margin and consider adding plasma treatment or hydropack. Wipe the anterior surface of the scleral lens while it's applied on the eye with the moistened cotton swab or scleral lens plunger, or use a device such as DMV plunger, or clean eye, the shadow applicator to clean the front lens surface. Place a drop of lubricating in the eye and rub the scleral lens surface with the device when the lens is applied on the eye. Different patients have predisposition to experience poor lens wettability and are those with blepharitis, demodex, and dry eyes from conditions such as graft versus host disease, Stevens-Johnson syndrome, severe meibomian gland dysfunction, blepharitis, rosacea, and atopic conditions. It's important to treat a pre-existing ocular disease prior lens application. Avoid plasma treatments or replace the scleral lens when the plasma appears with irregularities. And sometimes poor wettability is due to lab issues related. In these cases, clean with a lab strength cleaner if available, then clean and store with a solution of the care regimen. It's crucial to verify care regimen, plunger, hygiene, hand soap, cosmetics, and lotions. Hygiene and compliance are imperative. Avoid hand washing soap containing lanolin, moisturizing, or oil. Switching to soaps indicated for acne treatment. Apply the scleral lens before applying makeup and remove before makeup removal. Avoid cosmetics inside the eyelid margin again, and add to the scleral lens a plasma treatment called hydropack. Diet may also has an important impact as well. So varying diet, including the assumption of omega-3, avoiding fats and fried foods is indicated. So troubleshooting problems is fundamental in Scleral lens practice because most of the time lens decision is to use a Scleral lens represents a life-changing event for patients, and problems may result in eye surgery, depression, psychological problems, or emotional instability. On the other side, some practitioners do still remain intimidated by preconceived notion, the fitting process, and especially in the potential onset of problems and their management. As a consequence, clinicians rarely, if not at all, prescribe them. Increase of knowledge of Scleral lens fitting and management will allow expansion of the use of these lenses, and the beneficiaries of knowledge development and spread of Scleral lenses are our patients. Different sources are now available treating various aspects of Scleral lenses, and now just released the book discussing all issues and complications, proposing different management strategy. I thank you everyone for attending the meeting and for listening to this presentation. I hope to see you in person very soon. Thank you.